So to really understand the anterior shoulder dislocation, first we have to understand the anatomy of the shoulder joint. So the glenohumeral joint, which is also known as the shoulder joint, is a ball and socket type of synovial joint where the humeral head articulates with the glenoid. So the humeral head, which acts as the ball, as you can see in this picture, articulates with the glenoid of the scapula, which acts as the socket for this joint. And the shoulder joint, being a ball and socket type of joint, allows a wide range of movement, but at the same time, it makes the joint relatively unstable. And congruity of the shoulder joint is maintained by static and dynamic stabilizers that we will explain in the next slides. Now, starting with the static stabilizers, so the first one being the bone shape. So the bone shape being the humeral head as the ball is articulating with the glenoid as the socket, but the glenoid socket is a shallow concave surface. And if you compare it to the acetabulum, which is of the hip joint, it is much deeper. The acetabulum is much deeper than the glenoid, and that is why the glenoid provides much less stability compared to the acetabulum. The second static stabilizer being the glenoid labrum, which is a fibrocartilaginous rim which markedly increases the glenoid depth. So the glenoid labrum that you can see here in this picture, it make the glenoid cavity, which is here, deeper and make the joint more stable. The third static stabilizer being the joint capsule that you can see here in this picture. So it's a fibrous layer that surround and support the joint and act as a limiter to the external rotation. The fourth static stabilizer being the capsular ligaments. So those are superior, middle, and inferior glenohumeral ligaments that are attached to the capsule and on the joint capsule. And also there is the coracohumeral, the transverse humeral, and the coracoacromial ligaments, which make the joint even more stable. And the fifth static stabilizer being the negative intra-articular pressure, and that is produced by the intact closed joint. Moving on to the dynamic stabilizers, so those stabilize the joint during movements, and those include the rotator cuff muscles. So the rotator cuff muscles include the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. And those you can see in this picture here. So we have the supraspinatus, the infraspinatus, and the teres minor all on the posterior side of the scapula, and we have the subscapularis on the anterior side. And those muscles form a cuff around the glenohumeral joint, and they help keep the joint stable throughout movements. The second dynamic stabilizer being the long head of biceps brachii that you can see in this picture here. So this is the long head of the biceps in red, and it arises from the superior glenoid rim within the shoulder joint and travels over the anterior superior aspect of the humeral head downwards. And it is position, it works to resist the anterior dislocation of the humeral head. Now, with all those static and dynamic stabilizers, the shoulder is the most common joint to dislocate. It is 50% of all the major joint dislocations, so it forms a significant percentage of the joint dislocations of the human body. So why is that? Why the shoulder dislocates? Now, that is due to a number of factors. The first one being the shallowness of the glenoid that we already talked about, which articulate with a small part of the humeral head. So the shallow glenoid here, as you can see in this picture, is articulating with a small part of the humeral head, and that makes the shoulder joint is relatively unstable. Now, what also increase the rate of dislocations is the wide range of movements of this joint. Also, the underlying conditions such as ligamentous laxity or glenoid dysplasia, and finally the sheer vulnerability of the joint during stressful activities of the upper limb. So the shoulder joint is highly vulnerable to being dislocated, especially during stressful activities. Now, when the shoulder dislocates, it either dislocates anteriorly or it may dislocate posteriorly or inferiorly. But in this video, we will focus on the anterior shoulder dislocation. So, in anterior shoulder dislocation, there is complete anterior displacement of the humeral head out of the glenoid. And this is the most common type of shoulder dislocations. It forms 95% of all the shoulder dislocations. And in anterior shoulder dislocation, the humeral head lie either subcoracoid, which is most of the cases, so it either lies under the coracoid process of the scapula, or it may lie under the glenoid, so it is subglenoid, or it may lie under the clavicle, so subclavicular, or it may be intrathoracic, and that is very rare. And the anterior shoulder dislocation occur mainly in young men, more who play contact sports, skiing, and cycling. And in these type of activities, the shoulder is placed in at-risk position of abduction, external rotation, and extension, and then it pushed further beyond its range of movement. So in the mentioned activities, the shoulder will be put at risk position of abduction, external rotation, and it may be pushed out of its range, so it will be pushed backward until the humeral head here move from its position anteriorly. So it would be put in external rotation and abduction, and it would be pushed beyond that until the humeral head pops out. And that is when you have anterior shoulder dislocation. Now, 50% of anterior shoulder dislocation cases occur in elderly patients, and it is associated with rotator cuff tears. And the main mechanism in these patients is fall on the outstretched hand or fall on the shoulder while the shoulder being at risk position. And in patients with lax shoulders, there is minimal trauma may be involved to reach the shoulder dislocation. Now let's talk about the pathoanatomy of anterior shoulder dislocation. So what will happen after the shoulder anteriorly dislocate? So anterior shoulder dislocation result in a combination of one or more injuries to structures inside the joint and outside. And these injuries may include Bankart lesion. So Bankart lesion refers to avulsion of the anterior part of the labrum. So the glenoid labrum is the fibrocartilaginous rim that deepens up the glenoid, and the Bankart lesion is an avulsion of the anterior part of the labrum. And this is seen on the MRI scan. It cannot be seen on X-rays, and it is a quite common type of injury associated with anterior shoulder dislocation. Now we also have the bony Bankart lesion. So we have Bankart lesion and we have the bony Bankart lesion. And in the bony Bankart lesion there is an anterior glenoid rim avulsion fracture, and this can be seen on X-rays. And the bony Bankart lesion is shown in this picture here. So as you can see that we have a fracture of the glenoid rim that you can see in this picture here, and this is what we call the bony Bankart lesion. Now, anterior shoulder dislocation may result in the Hill-Sachs lesion, and the Hill-Sachs lesion is an impaction fracture of the posterior humeral head as it is compressed against the anterior glenoid after dislocation. So remember the at-risk position of abduction and external rotation. So let's say that this hand is the humeral head and this hand is the glenoid. So when there is an anterior shoulder dislocation, this hand would move like that out of the glenoid. And when it moves like that, first it may injure the labrum, which is this here. So it would cause labrum injury, and that is called the Bankart lesion. And it may also cause a rim fracture. So it would fracture the rim, which is called the bony Bankart lesion. Now also, the humeral head during the dislocation is compressed against the rim of the glenoid. So it would be compressed against the rim like that. And this might lead to the Hill-Sachs lesion, which is an impaction type of fracture that occur to the posterior part of the humeral head when it dislocates out of the glenoid anteriorly. So as you can see in this anterior posterior shoulder x-rays, we can see that the bone density of this part of the humeral head is much less than the rest of the humeral head. So this part here has less bone density, and there is the border also has a depression type of fracture here, and all of this is called the Hill-Sachs lesion. It affects the posterior superior part of the glenoid, as you can see in this picture, and it's an impaction type of fracture. And the Hill-Sachs lesion occur in 25% of first-time shoulder dislocation and in 75% of recurrent shoulder dislocations. And also, the anterior shoulder dislocation may result in fractures in the humeral head or neck other than the Hill-Sachs lesion, and it also leads to stretching or avulsion of the joint capsule during the dislocation, and anterior shoulder dislocation may also lead to rotator cuff tendon tear that occur in 40% of patients over the age of 40 years and 60% of patients over 60 years of age. So as you can see in this picture here, the tendon of the supraspinatus muscle is torn off, and the anterior shoulder dislocation may also result in a brachial plexus injury, which manifests as an axillary nerve palsy. And the axillary nerve would innervate the deltoid muscle. So when there is an axillary nerve injury, the deltoid muscle can't contract anymore. Now let's talk about the clinical features of anterior shoulder dislocation. So the patient will be supporting their arm with the opposite one, and they are in severe pain and muscular spasm. So the patient will come to you to the emergency department, and they are supporting their injured arm with the other one, and they are holding it close to their chest, and they will be in severe pain and muscle spasm. And they would decline any kind of examination because of pain, and lateral shoulder outline looks flat. So the shoulder outline of the affected shoulder is flat. It is not rounded like the normal, and with the prominent acromion. So the acromion would be prominent because the humeral head is dislocated. And if the patient is not too muscular, during palpation you would feel a bulge just below the clavicle, and that bulge is the humeral head. And always ask about the mechanism of injury. For the first time dislocations, there is usually a high energy trauma cause the dislocation, but recurrent dislocations will need trivial trauma or normal activities to be achieved. And mechanism of injury is important because it gives you an idea of the severity of the injury. And the arm must always be examined for nerve or vessel injury before reduction is attempted and after reduction is done. Now let's talk about the imaging in anterior shoulder dislocations. So the anterior posterior shoulder X-ray will show an overlapping shadows of the humeral head and the glenoid fossa, with the head lying below and medial to the glenoid socket. So as you can see in this X-ray here, so this is an AB shoulder X-ray, and it shows the humeral head here and the glenoid here. And you can see that the shadows of both bones are overlapping and the joint is incongruent, meaning the joint is dislocated and the humeral head is lying inferior and medial to the glenoid. And also on the AB shoulder X-ray, also look for fractures in the humeral head or neck. So always scan the X-ray for other injuries throughout the humeral head and throughout the clavicle, the acromion, the coracoid, the scapula, also the ribs, and the lung markings, looking for other injuries. Now, a lateral view, or also called a Y view, it would show the humeral head out of the line with the socket. So as you can see in this Y view, so this is the humeral head here, as you can see, and this is here the glenoid. And normally the humeral head would sit in the center of the glenoid, but here you can see that the humeral head is dislocated anteriorly. Now let's talk about the treatment of the anterior shoulder dislocation, and it is treated with reduction, and reduction is done closed in most of the cases and open in some cases. So let's start by explaining the closed reduction. So the closed reduction is the most effective and comfortable the earlier it is performed after the dislocation. And imaging is important to exclude significant fractures before the reduction is done. And the key in achieving successful closed reduction is muscle relaxation, because muscle spasm is what holding the humeral head from going back into the glenoid in most of the cases. So muscle relaxation is very important, so ask your patient to take deep breaths and relax their muscles during the reduction maneuvers. Now, various methods can be used to reduce the dislocated shoulder, but none showed convincing superiority over another. So they all can be attempted to reduce the dislocated shoulder. And the physician should be skilled at multiple methods and move fluidly between them until the patient's shoulder is reduced. Now, these methods can be used with or without sedation, and general anesthesia may be used sometimes. And simple traction is always helpful in relieving pain because it draws the humeral head away from the glenoid rim. So because the humeral head is pushed against the glenoid rim in anterior shoulder dislocation, this would lead to severe pain. So when you put traction on the arm of the patient, the humeral head would be pulled away from the glenoid rim, and that would lead to relieving the pain the patient experiencing. And in patient with the previous dislocations, simple traction on the arm might be enough to reduce the shoulder. Now we will start explaining the maneuvers. Remember, the shoulder might reduce at any point during these maneuvers, and always remember to ask your patient to breathe and relax their muscles, because relaxation is key in reducing the shoulder. So in the beginning of the reduction maneuver, start with gentle traction applied to the patient wrist or flexed elbow. So you stand on the side of the affected shoulder of the patient and you grasp the patient wrist or flexed elbow and you apply traction. And with the traction, you also externally rotate the patient arm slowly, and don't externally rotate quickly, because this may lead to aggravation of the patient pain and it may lead to aggravation of the muscle spasm. So always externally rotate slowly, and don't pull hard on the patient wrist or elbow, because this may lead to axillary nerve injury and fractures along the humerus. And also at the same time, don't let go of your traction, because this will cause pain and spasm at the patient's shoulder. So always maintain your traction throughout the reduction maneuver. And while maintaining traction, add Cunningham massage. With your other hand, you start massaging their trapezius, deltoid, and biceps. So same with the picture. So as you applying traction to their elbow here, with your other hand, which is this one, you apply massaging to their deltoid, trapezius, and biceps. And remember, during any of those steps mentioned, the shoulder might relocate and the reduction procedure end. Now, if the shoulder didn't relocate by now, you ask your assistant for applying a counter traction, which is also a very gentle traction to the body by a towel slung around the patient's chest under the axilla. And this is the Hippocratic method. So in Hippocratic method, you apply traction on the patient's wrist, and at the same time you apply counter traction on the patient body with a towel slung under their axilla. And as we mentioned, the humeral head might reduce at any point during the previous maneuver and the next maneuvers. So now again, you apply gentle traction, you externally rotate slowly, you use the Cunningham massage, and you use the Hippocratic counter traction method. Now after that, you apply the Spaso technique. The Spaso technique, you have to make the patient supine, because in the previous part, the patient was sitting. So you have to make the bed into the supine position, so the patient will be supine during the Spaso technique. And in the Spaso technique, you maintain your gentle traction on the patient's wrist, and then you lift their arm vertically. So you lift their arm vertically like that, and while keeping the traction, of course, and externally rotating the arm slowly. So you lift the patient arm vertically and externally rotate slowly while keeping your traction until you are in this position, and you keep your traction for several minutes and then you go back. And if the humeral head didn't relocate by this method, you move on to the next method, which is the Ferris technique. Now in Ferris technique, the patient also supine, and you also maintain your gentle traction as we mentioned, and then the patient arm is abducted and adducted by small movements, 10 cm each, while maintaining the traction and externally rotating the arm. So in Ferris technique, the patient arm would be abducted and adducted by small movements, 10 cm each, with externally rotating the arm. And remember, through all of these steps, you ask your patient to deep breath and relax their muscles. Now, if the Ferris technique fail, now comes the Milch technique. Now in Milch, the patient is placed supine too, And this technique takes 5 to 10 minutes, so it is done very slow. And if it's done quickly, it would be so painful. So it must be done slowly, and you flex the patient elbow and maintain traction. So in this method, the patient elbow will be flexed, and that is the opposite of the Ferris and Spaso, in which the patient arm will be straight. So in Milch, it will be flexed, and there is a traction done to the forearm like that, and you put your other hand on the humeral head. So one arm will be on the forearm of the patient that is flexed, and you maintain traction downward with it, and the other hand will be on the humeral head. And in Milch, then the patient arm is slowly and gradually abducted fully. And this done so slow, it is abducted until it is above the head. So once it is above the patient head, gentle external rotation is applied to the rest of the patient, and at the same time, lateral pressure is put on the head of the humerus. So there will be lateral pressure with the external rotation of the patient arm. And this is done for several minutes, for 5 to 10 minutes. And if it is failed, then comes the scapular manipulation technique. So in the scapular manipulation technique, the patient is now sitting upright. So the patient position is changed from supine to sitting in the scapular manipulation technique. And you will need an assistant in this technique. So ask an assistant to maintain the traction by pushing down on the patient flexed elbow. So now the traction will be maintained by an assistant. They will be pushing on the patient flexed elbow downward. And you stand behind the patient and rotate the scapula by using one thumb to push the scapula medially and the other thumb to push the acromion inferiorly. So one of your thumbs will be on the medial part of the scapula and you push it medially, so you push it inward, and the other thumb will be on the acromion and you will push the scapula downward. And with that, you are rotating the scapula clockwise or counterclockwise, depending on the right or left scapulae. And that is just to make the glenoid closer to the humeral head for it to get reduced. And there is another method that is used commonly, and that is the Stimson's technique. In Stimson's, the patient is put in a prone position, like you can see in this picture here, with the arm hanging over the side of the bed, and there is a weight attached to the arm, and the weight could be from 2 kilograms all the way up to 6.5 kilograms. And you wait for 15 to 20 minutes for the shoulder to reduce during this time. Now, after the shoulder gets reduced, the X-rays is taken to confirm reduction and exclude fractures. And active abduction is tested to exclude axillary nerve injury or rotator cuff tear. And other neuro and vascular exam is done, looking for arterial and other nerves injuries is done too. And after that, the arm is rested in a sling or a collar and cuff for 3 weeks in patients under 30 years of age to avoid recurrence, and for 1 week in patients over 30 years of age to avoid stiffness in these patients. And during this time, the elbow and fingers movements are practiced, and then the shoulder movements are practiced after the time ended. And the rate of recurrent instability will depend on the size of the Hill-Sachs lesion. So it will depend on the size of the fracture that is in the posterior part of the humeral head, and it will also depend on the presence of other bony injuries like the glenoid rim fractures, and it will also depend on the state of soft tissues. Now, the closed reduction is the treatment of most of the anterior shoulder dislocations, but a few of them will be treated with open reduction. So indications of surgery, which is an open reduction in these injuries, is either irreducible acute dislocation or a fracture dislocation, specifically the humeral neck fractures and displaced tuberosity fractures that doesn't reduce. So some of the humeral tuberosity fractures will reduce with the shoulder reduction, but the other ones will not be reduced. So those are the displaced tuberosity fractures that doesn't reduce, and those are indication of surgery. And surgery is also done in cases of neurovascular compromise and in cases of acute rotator cuff tears and in prophylactic stabilization in high chance of recurrence patients, especially patients who are aged less than 35 and intention to return to contact sports. And also surgery is done in stabilization in recurrent instability patients. Now let's talk about the anterior shoulder dislocation complications. So those include early complications and late complications. So starting with early complications, those include rotator cuff tear. So rotator cuff tear occur in patients that will have difficulty abducting their dislocated arm after reduction. So after reduction of the humeral head into its normal position, these patients will have difficulty in abducting their arm. And those, especially the old age patients. And with these patients, there is palpable contraction of the deltoid that will exclude the axillary nerve injury. So the diagnosis is rotator cuff tear. So these patients, when they try to abduct their arm and you would feel the deltoid, you would see that their deltoid is contracting. So this will exclude the axillary nerve injury, which is the other cause of abduction failure. So it has to be a rotator cuff tear that causes the abduction failure. And if there is a large tear, then repaired surgically, and if otherwise, then conservative treatment is better. Now, early complications also include nerve injuries, and the axillary nerve is the most common nerve to be injured in shoulder dislocations, and the patient is unable to abduct their arm, and the rotator cuff tears should be excluded by asking the patient to abduct while feeling their deltoid. If their deltoid doesn't contract, then it's an axillary nerve injury and it is not a rotator cuff tear. And axillary neurobraxia is the most common type of axillary nerve injury that occur, and this will recover after a few weeks. And also in the nerve injury, there is the radial nerve, the musculocutaneous nerve, median nerve, ulnar nerve, and brachial plexus. These also can be injured, but all are rare. Early complications also include vascular injury. So axillary artery is at risk of getting injured, especially in elderly patients with the fragile vessels, and it could be injured at the time of injury or during reduction maneuver, and examination is crucial before and after reduction to exclude this injury. An examination is by palpating the brachial pulse. And early complications also include associated fractures, and if the fractures just involve the greater tuberosity, then it might fall into place during reduction maneuver and no operation is needed. But if larger fracture or didn't fall into place during the reduction, then operative management is necessary to treat these injuries. Now let's move on to talk about the late complications. So in late complications, there is the shoulder stiffness. So in shoulder stiffness, prolonged immobilization after reduction may lead to this complication, and the risk of stiffness is higher in patients older than 40 years, and active exercises will loosen up the joint and relieve the stiffness. Late complications also include unreduced shoulder dislocation, which is an undiagnosed dislocation, and that is in patients being unconscious or very elderly patients, and close reduction is worth the attempt up to 6 weeks after the injury. And beyond that, manipulation may fracture the bone or tear the vessels or nerves, So open reduction is done to treat the unreduced shoulder dislocation. Late complications also include the recurrent dislocation. So the shoulder joint capsule is torn during the dislocation, but it heals once the joint is reduced. But if the glenoid labrum is detached or the joint capsule is stripped off the front of the glenoid neck, then healing is less likely, and this would increase the risk of recurrent dislocation. And also injury to the posterolateral aspect of the humeral head, which is the Hill-Sachs lesion, or presence of rotator cuff tears or greater tuberosity fractures increase the risk of recurrent dislocation much more. Now, how to diagnose the recurrent dislocation? So the history is diagnostic for recurrent dislocation. The patient complains of shoulder dislocation with normal everyday actions and often reduced by themselves, and any doubt in the diagnosis is solved by the apprehension test. And in apprehension test, the patient arm is abducted first and then laterally rotated. So they would be abducted and laterally rotated, and if the patient will resist this movement and apprehension from this movement by the patient, that is diagnostic for recurrent dislocation. And anterior-posterior shoulder X-ray with arm medially rotated would show the Hill-Sachs lesion for the most of the times in patients who have recurrent dislocations. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like this video and comment your ideas and questions. And this video is a part of a bigger class. It's called the Shoulder and Arm Trauma Masterclass. You can check it out if you want.